Good morning, dear students. It's my pleasure today to continue our journey studying and discussing the different CNS active drugs. After we finished sedatives, hypnotics, and anxiolytics, we are going to extend our knowledge to the chemistry of anti-epileptic agents, general anesthetics, stimulants, and we are going to understand the different chemistry, structural chemistry behind the different attitudes of these drugs and their limitations, metabolism, and possible drug-drug interactions. Starting with the anti-epileptic agents, it's very important to understand this class of medicine. It's very important to understand that the epileptical condition is a neurological condition that is mainly achieved or affected or is happening due to an electrical disturbance in brain, and this causes convulsions, loss of muscle tone, and sometimes in certain cases an alteration in consciousness. It's important also to understand that it is an idiopathic condition. It is non-age dependent. It is even cryptogenic. It might be caused by different types of traumatic influences, infections, CNS tumor or malfunction. It has different or many causes that might precipitate this condition. According to the affected site in brain, epileptic seizures can be classified into three types, starting from a partial seizure type to a general condition, that is generalized epileptic seizures, and then to status epilepticus. Partial seizure type of epileptic seizures is a disorder regarding a specific site at the brain, at one side of the brain. We can even subclassify it into simple partial seizure, complex partial seizure, and secondarily generalized seizure. These classifications are starting from simple conditions having no loss of consciousness, showing no loss of consciousness, starting from just jerking movements, confusions, and ending with this secondarily generalized seizure that is a complex condition involving, as I told you, one side of the brain, accompanied by loss of consciousness and involuntary behavior. Regarding the generalized seizure, it is affecting the whole brain, and we can classify it into tonic-clonic, which is named grand mal epilepsy, or absence seizure that is known or named petit mal. These are the different symptoms related to these two types. The generalized seizure, the tonic-clonic type, is characterized by tonic phase, which include muscle spasm, where convulsions, consciousness loss is occurring, followed by an alternate muscle relaxation. That's why it is termed tonic-clonic. Tonic where the spasm occur, and when relaxation, this is the clonic phase. It affects the smooth muscles even of the bowel or the urinary tract, where losing of bowel or urinary control. A seizure may last for 2 to 3 minutes. A severe headache is following the tonic-clonic phase, and this is less frequent in children, whereas the absence seizure, which is Dipakoate, it usually occurs in children. It has minor movement in head and eyes, loss of attention, total loss of attention. You can notice a short cessation in physical movement. The third type, which is a life-threatening condition that is involving the whole brain, is the status epilepticus. It is a life-threatening condition, as I told you. It is prolonged, repeated, the seizures I mean. Maybe the patient is not restoring the normal consciousness between two epileptic seizures. Patient should be hospitalized, and treatment should be controlled and monitored inside the hospital. Please don't forget that when we are treating epilepsy, we have to consider the GABA mechanism of action. We have to consider that GABA potentiation is one of the important strategies in treating epilepsy. We might interfere also by inhibiting the sodium influx or the calcium influx. Sometimes adjunctive therapy can include inhibition of the excitatory amino acid neurotransmitters. Then we have, as I told you, many strategies to treat epilepsy, either to interfere with GABA, sodium or calcium influx, or even the other amino neurotransmitter inhibition that are excitatory in nature. Before starting the different classes, after having a look to this scheme, we can notice that we have here, I don't know if you are seeing my cursor, I'm trying to highlight where I am. Benzodiazepines, barbiturates, we have already discussed. They are acting on potentiating the GABA effect on the GABA receptor. That's why they are affecting chloride channels. We can find other derivatives that are directly affecting chloride channels, such as progaboid, which is a Gabamimetic agent. Regarding the indirect way to potentiate the GABA mechanism, we can increase, enhance, potentiate the production of GABA, and this is by improving the utilization of GABA precursor to end with a higher degree or input of GABA as a neurotransmitter. We can even potentiate GABA effect by inhibiting the metabolism of GABA, preventing it to be converted to the succinic semialdehyde and then succinic acid using this vigabatrin. We can even inhibit not only the metabolism, we can inhibit the reuptake of GABA through such derivative. So this slide is orienting our mind that there are some drugs that are differently acting in order to enhance the GABAergic synapses, or to potentiate the GABA presence synthesis, preventing metabolism, preventing reuptake at the synaptic cleft. Please don't forget this scheme. It was discussed last lecture, and this is summarizing what we have said now. We end with a potentiation of the GABA effect. A short look to phenobarbital, that we can also name phenobarbital. This phenobarbital and its corresponding unoxidized form, the primidone, where a carbonyl is absent. These two derivatives are having pharmacokinetic properties regarding their duration of action, permitting the achievement of a good response for a proper time, preventing the formation or the presence of seizures outside home with the patient. So they are mainly used as we discussed before. Primidone is the unoxidized form of phenobarbital that will be converted even to phenobarbitone by oxidation at this carbon level to produce the phenobarbitone itself or the phenobarbital itself. Another concept I want you to realize, that we may use such derivatives as sodium salt injections. In this way, we are benefiting the presence of the drug in a freely water-soluble state that can be administered as injection or even infusions to control the convulsions that might occur, that are definitely occurring in status epilepticus. As I told you that this case, the status epilepticus, is a hospital condition and it is life-threatening. The anticonvulsant benzodiazepine, clonazepam, it is the selected one of the benzodiazepine derivatives to be used as anticonvulsant. This is owing to its proper pharmacokinetic properties suiting the prevention of seizures. Valproic acid is the candidate number 4. I want you please to analyze the structure of this valproic acid. We are going to notice, please count with me the number of carbons. It's 1 starting here, 2, 3, 4, 5. It is a pentanoic acid having at the 2 position, the adjacent carbon to the carboxylate, a 2-propyl function. It is formulated as sodium salt. Please try to compare the structure of valproic acid to GABA itself. I want you to remember what is GABA standing for. Valproic acid here is having an effect to elevate levels of GABA in brain because it acts as a GABA transaminase inhibitor. GABA transaminase inhibitor. So this is the inhibitor of the enzyme that metabolizes GABA. That's why it extends the presence of GABA in synapse. Valproic acid is the drug of choice in petit mal. It is tolerated. It is metabolically converted into many metabolites. The problem here that it is readily converted to this epoxy form where an epoxide function is occurring terminally. Or it is converted to a conjugated derivative, a diene, as we can see here, a diene having double, single, double. Both these are easily precipitating the formation of free radicals, and they have their own toxicities either on the hepatic level, the liver, and they are known to be teratogenic in nature. That's why valproic acid is always prevented and not used in pregnancy, and of course it is obsolete to use it for a borderline hepatic patient. It's not used for treating epilepsy in patients known or recognized with hepatic history. Coming to this derivative that represents a more water soluble of the valproate, that is a sodium valproate and valproic acid in a mixture of 1:1. Again, it is the same as valproic acid, of course. It is a transaminase inhibitor, sometimes used in migraine, headache, and even in schizophrenic cases. The gabapentine, and again, I'm asking you to compare the structure with GABA. Don't forget that GABA is gamma amino butyric acid. Have a look here. This is the gabapentine, and if we can notice alpha, beta, gamma in respective to the carboxylate. So at the level of this extended chain, we have a gamma aminobutyric acid. It's a GABA analog still, but having a cyclohexyl function. Where it is present, this cyclohexyl, it is present on the beta carbon of the acid chain. Okay, the gabapentine, its mechanism of action is well known to improve the utilization of GABA precursor, which is the glutamate. The glutamate is the precursor of GABA, so it increases the synthesis of GABA in brain, and in this way it enhances the GABA potential. It is renally excreted, unmetabolized, so please notice that such a structure is not recommended for renal patients, for those patients that are borderline kidneys or that are known to have kidney malfunctions. Topiramate, which is one of the monosaccharides related derivative. It is related to fructose. It is a lipophilic derivative of fructose, having a sulfamate substitution. It is a sulfamate here. We mean that it contains in its structure a sulfone amino function related in an ester function to the OH of the monosaccharide. It acts by activating the chloride channel and hence inhibiting the excitatory neurotransmission. It is used in many conditions, certainly in epileptic treatment for children and adults, and as well it is approved to prevent migraines and to stabilize mood, and even in treatment of obesity. Vigabatrin is one of the gamma aminobutyric acid derivatives, and as we can see, it is a gamma vinyl derivative, gamma vinyl, starting here, this is alpha, beta, gamma, where the gamma is having the amino function and as well a vinyl function, and we can recognize the vinyl substitution even in the name of the derivative. It is potentiating the GABA effect by preventing its metabolism, and hence levels of GABA increases in synapse. This structure, which is the progaboid again, and I want you to count with me the number of carbons. If vigabatrin is the free acid derivative, this is the carboxamide derivative, where this is the alpha carbon, beta, gamma again, where the gamma is having its nitrogen function, and it's the turn of the nitrogen function to carry the two aromatic functions on one carbon. And as we can recognize that this structure is metabolically stable, where the liable positions for metabolism are blocked. And please, this requires that you revise a little bit the hydroxylation metabolic pathways that occur on the aromatic systems. The mechanism of action of this progaboid is acting as a direct GABA-A agonist. I want you to believe in the fact that these derivatives were all produced taking GABA as a lead structure and trying to invent newer structures that are containing in their core the basic structure of GABA, trying to affording better pharmacokinetic properties or better interaction with the active sites. Coming to the tiagabine again is a GABA-related analog. While it needs some analysis in the structure, if we can look to this carboxylic group and count with me, please. This is the alpha, beta. So the nitrogen, if we are looking to the structure from this side, is the beta substitution, and from that side on the piperidine structure, it's alpha, beta, gamma, delta. It is the delta substitution, and again there is a butane tail or spacer between the nitrogen and the two aromatic thiophen that are even again mimicking the two phenyl groups present located on one carbon, that is sp2 carbon, as the case of progabid. And this tiagabine, once developed, it was found not to act directly on the GABA-A receptor as an agonist, but it was acting as a reuptake inhibitor. It is a selective reuptake inhibitor of GABA, and hence potentiating the effect of GABA on its receptor. The second class we are going to discuss as another mechanism of action to prevent the formation or the occurrence of seizure is those drugs acting on the sodium ion channel. They are acting to inhibit this sodium ion channel, and we can find 5 candidates in this class: the phenytoin, the fosphenytoin, and please here we have to work a little bit on the pharmacokinetic perception. Are we intending to produce a prodrug that is water soluble of the phenytoin? Yes, we are going to realize this. Carbamazepine and oxcarbazepine and we have to find the relation between them regarding the toxic effect or the cytotoxic effect of carbamazepine, where it is able to produce free radicals, and how is oxcarbazepine preventing this. And we are going to end this subclass by lamotrigine. Phenytoin, it is an example of a ring-contracted analog of barbiturate. Barbiturate, as a barbituric acid analog, it is a pyrimidine structure, 6-membered ring. Phenytoin is related chemically to barbiturate while being ring contracted, a 5-membered ring instead of 6. It is a Hydantoin analog, and the name, I want you to trace it and to know when to use the Hydantoin as a name. Mainly it is an imidazolidine structure. Imidazolidine, that's to say 5-membered ring containing 2 nitrogens that are 1,3, and it is fully saturated, and being fully saturated and possessing 2 own functions on 2 and 4, then it is an imidazolidine 2,4 dione structure. I can recognize here the proper pharmacokinetic attitude of the structure, where it is lipophilic to penetrate into blood-brain barrier, and at the same time it is having 2 phenyl groups. These 2 phenyl groups are preventing it owing to their pi systems, preventing it to come directly outside the CNS. That's why it is proper in pharmacokinetic properties regarding specifically duration of action to prevent the occurrence of seizures. It is used in grand mal, status epilepticus. It is never used in petit mal, never. Some side effects are known or known to occur during phenytoin treatment, the gingival enlargement, sometimes bleeding, and loss of bone in the mandibles. The fosphenytoin is the phosphoric acid prodrug of phenytoin, where phosphoric acid is related in structure, I don't want to say related, rather it is connected to the structure through this carbon, which is a methoxy. If we want to analyze it, they developed a methyl hydroxy analog of phenytoin, and they used the OH of the hydroxy methyl function to be esterified with phosphoric acid. Then this is the phosphoric acid ester of methoxyphenytoin. Maybe you didn't realize this concept before, that we are producing a prodrug in order to obtain this time a water-soluble derivative rather than to obtain a more lipophilic derivative. Is it of value? Yes, sure, it is of value when treating patients that need to be administering the drug through parenteral route. Because this phenytoin related drug is a totally water-soluble drug, and we can formulate it as intravenous infusions or injections to be intravenously administered, and it is helpful very helpful in treatment of status epilepticus, and sometimes even it is used to control seizures during anesthesia and brain surgeries. What I want to tell you that it's a type of prodrug formation aiming at solubilizing the derivative and not to extend its duration of action or to render it more lipophilic so as to be more penetrable. No, this drug is a prodrug waiting for hydrolysis to free the phosphoric acid part and yielding a derivative of phenytoin that is properly acting on the GABA receptor. Carbamazepine, as you can see it, it is a three ring system derivative fused. It is a dibenzoazepine structure. You can recognize this well, having a 5-carboxamide function. That's to say the nitrogen on position number 5 of the structure is involved in a carbamate bond to have this carboxamido function. This one. This structure is used as a monotherapy in grand mal epilepsy, in bipolar disorders. It is a sodium channel inhibitor, as we classified it. Its problem is that upon its metabolism, it is able to be converted by oxidation into the epoxide derivative, as you can recognize it here. The epoxide derivative, which yields upon a hydrolase enzyme, which yields to the formation of 2-hydroxy. Up to the level of an epoxide, it is still active, carbamazepine, and when it is converted to the dihydroxy, it is inactive, and of course, the formation of such highly oxidized derivatives are a source of free radical, and a corrective drug design had to be taken in order to overcome the toxicity of the epoxide, specifically the epoxide, as it is able to produce a case of anemia that is known to be aplastic anemia due to its oxidative effect. The oxcarbazepine were an additional oxo group, this one. An additional oxo group was allocated on the 10 position in order, and of course we can notice that the double bond went away. The oxo function on the 10 position facilitated the innovation of this drug, the oxcarbazepine. This oxcarbazepine is known to have an anticonvulsant and mood stabilizing effect. It is not converted to the epoxide form and hence the dihydroxy form. It is only converted to the 10-monohydroxycarbazepine. Such a structure was designed to reduce the impact on the liver. So a pharmacokinetic attention was the cause of designing this structure. Aplastic anemia was they prevented the formation or the happening of aplastic anemia. And again, the carbamazepine and its derivative oxcarbazepine are known to be sodium channel inhibitors. Lamotrigine, the Lamictal, and please again have a look on the labile positions on the susceptible metabolic sites of the structure. They were blocked by chloro. Two chloro functions are here to compensate for the high hydrophilicity that is accompanying the high nitrogen content in this triazine diamino derivative. Two chloro substitutions are compensating this hydrophilic effect. They are affording lipophilic attitude to the structure and permitting it to penetrate blood-brain barrier. It is an inhibitor of the sodium channel, as we told you, and again, it might be used in treating the manic phases of the bipolar disorders. The third subclass of anti-epileptic drugs is known to be drugs with other mechanisms of action than GABA potentiation or sodium channel inhibition. We can find the first one here in this class, the famous derivative, which is ethosuximide, used mainly to treat petit mal. And as we can see, it is the carbon isoster, it is the carbon isoster of Phenytoin. It is a succinimide having alkyl substitutions rather than aryl substitutions, and as I told you, it is the carbon bioisoster to Phenytoins. Such derivative, as I told you now, it is specifically treating the absence seizure, or what is known as petit mal, and its mechanism of action is by deactivation of calcium channel and hence suppressing the excitatory response. Felbamate, which is a dicarbamate structure. Dicarbamate, that's to say it has a carbamic acid residue. Carbamic acid residue. This carbamic acid is involved in bi-ester function with this propane diol, carrying this phenyl ring on its intermediate position carbon. So it is a dicarbamate analog defending its penetration to a blood-brain barrier. It is having dual mechanism of action. It is acting on the GABA binding site. At the same time, it is known to be an NMDA receptor antagonist. NMDA is an excitatory receptor, so by acting on this NMDA receptor as an antagonist, it suppresses the CNS stimulation. Coming to these two derivatives, again we can find a chance for isosteric replacement, even bioisosteric replacement. We can find that this is the oxygen analog, the oxygen bioisoster of either Phenytoin or ethosuximide, having still alkyl chain rather than aromatic chains substitutions, and it is well known to be highly I don't want to say toxic, but having very It is contraindicated, definitely contraindicated in pregnant women, as it might lead to fetal loss and mental retardation. That's why it is never used to treat pregnant women. It is used sometimes, it is reserved due to its high risk. It is reserved to treat epileptic conditions when the other treatments are not effective. Again, I want to let you remember that from their name, trimethadione, always please relate the name to the structure, and this will facilitate the data keeping power. And here it is a paramethadione, where one of the methyl functions is augmented, expanded to an ethyl function. Acetazolamide, the well-known carbonic anhydrase inhibitor, it is decreasing the accumulation of carbon dioxide in brain and spinal cord, and it is used as an adjuvant treatment in petit mal and sometimes used in generalized epileptic conditions, and it is concomitantly used with other drugs. Please, I want you here to recognize some pharmacokinetic aspects, as I told you, that might lead to drug-drug interactions and inactivation sometimes. The factor here is phenobarbitones, phenytoin, carbamazepines are known to be enzyme inducers. They are inducing the hepatic microsomal network, so as they may result in inactivation, and they can increase the metabolic inactivation of other drugs. The combination between the anticonvulsant agents and other drugs sometimes is needed to be monitored because some important drugs might be inactive, such as, for instance, drugs treating coagulation. The parenteral anticoagulant, for instance, the oral anticoagulants, these derivatives are important to be monitored when they are administered at the same time the patient is using such inducers of the enzymatic network. Gabapentin, and we described this before, gabapentin is renally excreted, and it is excreted unchanged. That's why we have to consider the renal condition of the patient before the administration of the gabapentin. Please notice that many of these drugs are used for other medicinal purposes than anti-epileptic effect. We can find some drugs that are used in neuropathic pain, like carbamazepine, phenytoin, gabapentin, lamotrigine. Others are prescribed in migraine prevention, like the Topiramate and the Depakoate, which is the valproic acid mixture. Some others are used as mood stabilizers, again, like the phenytoin, carbamazepine, gabapentin, and lamotrigine. Till here, we finished our first part of the lecture. Thank you for watching. We finished the anti-epileptic drugs, and in the second part we are going to start with the anesthetic agents and with the CNS stimulants. Thank you.